So let's talk about a little bit. I want to start talking about liver and pancreas imaging. And both liver and pancreas are key organs in the abdomen, but I always think about the relation between the liver and the pancreas with this picture. This is the liver, much more powerful, and this is the pancreas, which is smaller, longer, thinner, and cuter. But we pay a lot of attention to tumors in the liver, tumors in the pancreas. We pay attention to inflammatory changes in the liver, including diffuse hepatic steatosis. But here is poor pancreas. Important to know about pancreatitis, because pancreatitis, as the title of this presentation indicates, is a very common disease, a very common process, but also can be very critical and has significant mortality in patients that have a severe pancreatitis. So these are our learning objectives. We'll talk about acute pancreatitis. We'll talk a little bit less about chronic pancreatitis, and we'll talk a little bit about the imaging appropriateness criteria. A little bit about that. I had the privilege to, in 2006 to 2008 or 9, to be in the ACR appropriateness criteria for pancreatitis. There was a bunch of radiologists and gastroenterologists, and we will, if we have time, we'll talk about this at the end of our presentation. So let's talk about acute pancreatitis. Again, thankfully, this common disease is, in the majority of the cases, 80%, the Pareto principle, 80% is interstitial or so-called edematous, with minimal organ failure, with an eventual recovery. At integrum, the pancreas doesn't have any signs that has had pancreatitis, and with supportive therapy, patients do fine, and many, many times don't get to even to be imaged. On the other hand, about 20% is called necrotizing pancreatitis. We can, with imaging, particularly with CT, diagnose necrotizing pancreatitis, and necrotizing pancreatitis implies organ failure with local complications of necrosis, abscess formation, pseudocyst formation, requires intensive monitoring. Patients that get repeated CTs do better than the ones that are not imaged or sparsely imaging. And there are very specific therapies, and the prognosis is guarded with significant amount of mortality. So that's the common and critical components of acute pancreatitis. Acute pancreatitis, basically the modality of choice is CT. CT has many advantages. It's accurate, reproducible, available. I would add is pretty much goof-proof. You have to be a very bad radiologist to get a bad CT, because CTs in general, modern CTs are very fast, and the quality is excellent. And CT allows staging of pancreatitis with calculation of the severity index. Nothing has really changed in the last 20 years in the imaging of acute pancreatitis. The principles started at the beginning of CT in the 1980s, but since 2000 plus, with some variations, we have in the right track for the diagnosis and staging of acute pancreatitis. Certainly, CT is a modality of choice. MR can be used, ultrasound can be used, particularly in less severe cases, but at the end of the day, CT in patients with serious, concerning acute pancreatitis is the way to go. CT findings, again, haven't really changed in 20 years. Basically, you have to look at the pancreas, but I always tell our residents, look also outside the pancreas and the peripancreatic area, but also far from the pancreas in the rest of the abdomen and chest. So the classic findings are swelling of the pancreas, necrosis of the pancreas. Obviously, the necrosis is essential because that means that you are dealing with necrotizing pancreatitis. Peripancreatic fat strandiness and peripancreatic fluid collections are part of the severity of pancreatitis. And then the extrapancreatic complications such as ascites, pleural effusion, vascular complications, and then parenchymal organs, solid organs, or gastrointestinal tract involvement also increase the staging and the rate of complications and severity of pancreatitis. Classic examples, you have inflammation, as we mentioned, inflammation or swelling that can be focal. In here, it's just pancreatic head pancreatitis. The tail of the pancreas and the body are not so bad, and the tail certainly has no peripancreatic fat strandiness. It can be diffuse. The whole pancreas with diffuse is involved and swelling, and with swelling, and also diffuse peripancreatic strandiness. Necrosis can be focal or can be larger, but this is an area of no enhancement. This area here, but also the head of the body and head of the pancreas do not enhance. And then peripancreatic fluid collections and peripancreatic strandiness here more and more, with involvement of basically the entire retroperitoneum and also involvement of the GI tract. A key finding is the potential presence of pseudoaneurysms, small one here, a larger one here, more if you want longitudinal, but this is pseudoaneurysm. What happens is that the peripancreatic fluid is not ascites, is actually the pancreatic enzymes that are auto-digesting the retroperitoneum and are digesting the pancreas. Part of the digestion of the pancreas with necrotizing pancreatitis or digestion of the peripancreatic fat, as you see here. It can be also involvement of the arteries. The arteries are basically bathed in pancreatic juice that is equivalent to meat tenderizer, and then the wall, the not the intima, but the muscularis propria of the artery becomes swollen and weak and can have pseudocyst formation, as you see here. That is the same patient, and you see, this is the prior patient, and this is the same patient with longitudinal pseudoaneurysm that you see here in this vascular three-dimensional color reconstruction. And obviously, pseudoaneurysm is very prone to bleed and have hemorrhagic necrotizing pancreatitis, which is very, very high mortality, almost 100%. So in MRI is, again, from 20 plus years ago, it was said that the accuracy was similar than CT, less availability, higher cost, and I would add a little bit more of a gamble, because the same way that CT almost always is of good quality, MR varies tremendously, and these are sick patients that can move, and then the whole scan is full of motion, patient motion, and it's not as accurate as CT. Advantages: no contrast in patients that are really with severe demonstrated allergies to contrast, no ionizing radiation, and obviously you can be better at the etiology of the pancreatitis, because something that CT is not so good, but MR is excellent, is to study the biliary tree, and then you have SMRcp component in the evaluation of pancreatitis, and you can see gallstones, pancreas division. Also, MRI is excellent with very sensitive in T1 and some in and out phases to detect hemorrhage in peripancreatic collections. And again, hemorrhagic pancreatitis has a different level of concern for the surgeons that are treating patients with severe acute pancreatitis. And again, prior to catheter drainage, some people like to do an MR, make sure that there is no hemorrhage within it. Majority of now severe pseudocysts are drained by endoscopic ultrasound doing a pancreatic gastrostomy. Use of MRI is debatable. Use of CT is the modality of choice. See examples here of acute pancreatitis, similar than in CT, the diffuse involvement of the pancreatic parenchyma, or in here, the production of pseudocyst formation, or maybe in the acute phases, would be just peripancreatic fluid collections or phlegmon. Here, just to show that in the fat suppression, you can see a small area of hemorrhage. That is a big concern for the surgeons. And here with gadolinium, you see the strandiness of the peripancreatic fat very nicely. Again, SMRcp allows you to see, this is a very large dilatation of the pancreatic duct. But in here, you can see the pancreatic duct, the common bile duct and the pancreatic duct displaced by this large fluid collection, peripancreatic phlegmon in V1. And again, just pointing out that you can see gallstones or you can see the displacement and the obstruction of the common bile duct by the displacement and the narrowing of the common bile duct by the large peripancreatic phlegmon. Complications. Complications are pseudocyst. It's a collection of pancreatic juice enclosed by a wall of granulation tissue. To form the granulation tissue, you have to wait at least 6 weeks. So no surgeons wants to hear the word pseudocyst in a patient with acute pancreatitis without 6 or 8 weeks of interval between the event of acute pancreatitis, the formation of peripancreatic phlegmon or collections, and then eventually will be a formation of the granulation tissue and the pseudocyst. It can be infected necrosis, infection of a focal or diffuse area of non-viable necrotic pancreas. That will be infected necrosis first. That will, if not treated, evolve to a pancreatic abscess. By definition of abscess is a localized or circumscribed collection of pus containing little of non-necrosis, because inside is all the liquefactive necrosis, if you want, of the pus. So examples of pseudocyst formation. This is a florid case with large pseudocyst. This is well established. The pancreatitis was several weeks ago, and here is a pseudocyst involving the liver in the subcapsular location, involving the wall of the stomach, involving the perisplenic area. Infected necrosis goes from just a little bit of bubbles of air, liquefaction, to here, little bubbles of air. Air is concerning, and then necrotizing abscess basically becomes plenty of air and all the trappings, all the clinical findings of abscess formation. Something that is not so known, that at the beginning of pancreatitis, people were not paying as much attention as we do now, is solid organ involvement. The spleen, particularly for pancreatitis involving the tail, is the most commonly involved organ, then the kidney, and then the liver. Obviously, the spleen is much less cellular. It's just vascular channels and white pulp. It's less cellular than kidney, and kidney is more cellular than is less cellular than liver. At the end, the more cellular and packed is the organ, less chances for, if you want, accepting complications of acute pancreatitis. But pseudocyst formation can occur frequently in the spleen, the kidney, or the liver. Infarctions of any of these solid organs that are in the upper abdomen. The GI tract can be involved with inflammatory changes, so focal colitis or enteritis, and then the sequelae of a stenosis, or again, the pancreatic enzymes can perforate the same way that can chew on a vessel and produce pseudoaneurysm formation, can also produce perforation of fistulous tracts between the pancreatic or peripancreatic phlegmon and the GI tract, particularly the left colon or the duodenum if it's pancreatic head. Vascular complications, common venous thrombosis, less common, the deadly complication is pseudocyst formation. Examples here of pseudocyst, or not pseudocyst, peripancreatic phlegmon involving the spleen, or here involving the liver, the wall of the greater curvature of the stomach, and in here a nice example, the portohepatis, nice example of a pancreatic or a splenic infarct secondary to obstruction of the splenic artery that courses through here inside the area of pancreatitis. Nice example as well here is thrombosis of the vessel, or here the involvement by phlegmonous collection of the left lobe of the liver. Stenosis of the duodenum can be like we see here, or colitis surrounding the ascending colon by the pancreatitis that it's involving the head of the pancreas. Stenosis, as you can see here, of the colon. There is an old finding in KUBs called the colon cutoff sign that you can see dilatation of the transverse colon and then basically no air after the splenic flexure. And that is what we see here, large peripancreatic phlegmonous collections with involving the splenic flexure. And here, marked stenosis of the same with marked proximal dilatation. So this would be the CT appearance of the colon cutoff sign with obstruction here. Venous thrombosis in many levels. This is the whole splenic vein thrombosed. Here, the superior mesenteric artery has been thrombosed in patients with pancreatitis. 17% of acute pancreatitis will have involvement of the splenic vein, 8% of the superior mesenteric artery. Pseudoaneurysm information, we already mentioned the dreadful complications. This is such an example. So every time you see pancreatitis, look around. If you see a little aneurysm, that can be here a very uncommon complication, about 1%, but can, or another example here, these are little, not so little aneurysms that can bleed and produce a emergent surgery situation. So the scoring systems, there are clinical scoring systems and radiological scoring systems. Dr. Ranson was a very famous chief of surgery at NYU, close to us in Manhattan. And Dr. Ranson was a surgeon, and he developed these criteria that are basically clinical criteria. They talk about heart rate, pulsation, fever, and other level of lipase and amylase. It's purely clinical. These were modified, the so-called Apache 2 classification, that basically talks about acute physiology and chronic health. And obviously, the translation of this was the radiological CT Severity Index. Dr. Baltazar was the chief of abdominal imaging in the 1990s at NYU, so he was contemporary when they were talking about the Apache clinical criteria. And NYU developed a severity index that basically allows, very much like the Ranson criteria, to prevent the outcome of acute pancreatitis. The more severity is the index, less chances of survival or complete cure. And the same would be with the Baltazar criteria. I was privileged to participate in this group at the Brigham and Women's Hospital, where I used to work. We put together a modified CT severity index I'm going to share. They have, at this point, the severity index. You don't stage at this point pancreatitis, but in some hands, particularly depending upon what the clinicians want, the radiologists are asked to provide a CT severity index. This happens in centers where they do care for acute pancreatitis. And I would say that in many urban areas of the different offerings that there are, there is always one center that it's more interested in acute pancreatitis that requires, again, intense care after the diagnosis. So this is the Baltazar criteria. It's basically a point criteria that can get to 10 points, actually. There are 4 points that go to count, if you want, that pancreatic inflammation. So how much inflammation is in the pancreas, from 0 to 4. Obviously, if you have 2 or more collections, peripancreatic collections, or gas in or adjacent to the pancreas, will be 4. And then the amount of necrosis, which is difficult to determine. No necrosis is difficult, it's easy. More than 50%, it's easy. But one of the problems with this index criteria is that if you're not using it several times a day, you get a lot of inter-observer variability between 30% or between 30 and 50%. Not so easy to do. So nice examples: normal pancreas, diffuse enlargement, peripancreatic fat inflammation, and here single fluid collection. It gets worse with 2 or more fluid collections or air in the pancreas. These are the E category. And then you can again argue it's easy when it's small amount of necrosis, a larger amount, there's a big portion of pancreas here, but less than 50% that it's missing. The head and the tail are still enhancing. And here, except for a little bit of the enzymatic process, the whole pancreas is necrotic, the most severe index of pancreatic necrosis. The limitations when you use, among the centers that they use Severity Index, there's in the Balthazar criteria, there's no consideration for organ failure, there's no consideration for extrapancreatic complications, or parenchymal, meaning kidney or liver or spleen or vascular complications. So they don't really count the added severity, if you want, of having SMA thrombosis or a phlegmonous fluid collection inside the pancreas. With the Balthazar Severity Index, there is under 75% moderate inter-observer agreement with complex catheterization, particularly necrosis. It's complicated to assess consistently among readers. So there was a need for a simplified index. I don't know if we simplified it or not, but we added the extrapancreatic complications that it seems to work a little bit better. And Dr. Banks, the gastroenterologist, wanted to have a reliable severity index that among all the others that were radiologists, we will not increase up or increase down the severity index. So the CT findings now, we've finished with acute pancreatitis. Let's talk about chronic pancreatitis. The findings are well known to majority of people in the pancreatic parenchyma. You look for atrophy, you look for calcifications, you look for pancreatic duct dilatation. You also look for normal or abnormal attenuation and for areas of heterogeneous enhancement. In the peripancreatic tissues, you look for pseudocyst formation. In chronic pancreatitis, you look for tapering, decreasing inside common bile duct because of the displacement by the chronic pancreatitis. And you see alterations of the peripancreatic fat and a peri-inflammatory mass. So classic examples of acute pancreatitis with classic atrophy of the pancreas, dilatation of the main pancreatic duct, and multiple chronic pancreatic calcification, chronic pancreatitis. Same here with dilatation of the pancreatic duct, or other examples here, massive, if you want, calcifications throughout an enlarged pancreatic head. You can see the ampulla enlarged here, or severe pancreatic atrophy with marked pancreatic duct dilatation and calcifications in the tail of the pancreas. Here, another complication that we mentioned is pseudocyst formation and dilatation of the pancreatic duct in a C, if you want, of acute pancreatitis. MR findings: in T1, the pancreas is less juicy, if you want. I worked with a pathologist in Washington at the AFIP that said the pancreas in pancreatitis becomes pickled. And it's the same between a fresh cucumber and a pickled cucumber. It's drier. So the T1 decreases in signal. The T2 is more variable, maybe normal. The enhancement is less and delayed. In MR, obviously, do not depict at all the calcifications. CT has, this is one of the major advantages. But the advantage using MR for chronic pancreatitis is allows you to see very nicely the pancreatic duct, the common bile duct, and see with better splendor, if you want, the extent of morphologic ductal changes, and basically classifies better the severity of chronic pancreatitis. Examples of chronic pancreatitis. You see here the appearance of T1, a little bit of modest enhancement of the area of chronic inflammation, and this is the appearance in T2. Nobody will escape, that will not escape to anybody to understand how difficult by MR or with CT is a differentiation of focal chronic pancreatitis with a pancreatic neoplasm that to this date is not 100% possible. Although obviously, if in a case like this, if this is considered potentially for a pancreatic tumor, it will represent Whipple resection, which again, at the end of the day, Whipple is a very damaging surgery. Obviously, is a salvage surgery that is maybe the only hope for people with pancreatic cancer, but it's certainly not needed in patients with chronic pancreatitis. But chronic pancreatitis is one of the accepted errors in surgery for Whipple disease because you cannot distinguish between chronic pancreatitis, focal chronic pancreatitis, and focal adenocarcinoma. Again, similar examples. You see here the little bit of less enhancement than normal of the pancreas and the dilatation of the pancreatic duct, but you don't see the calcifications. Here, examples of the tortuosity, dilatation, a little bit of arborization, meaning chronic dilatation of the pancreatic duct, less severe, more severe in chronic pancreatitis. And here, obviously, we go from modest to very severe, two different examples of chronic pancreatitis with marked dilatation of the pancreatic duct and these areas that you could consider dilatation of branches through the entire pancreas of the pancreatic duct, side branches, maybe with some tiny pseudocyst formation. Same in here, marked severe dilatation of the common bile duct, common pancreatic duct in patients with chronic pancreatitis. I want to talk a little bit about two special situations of chronic pancreatitis. One is called groove pancreatitis. It's a special form of chronic pancreatitis that occurs in the so-called surgeons call the groove of the pancreas. The groove of the pancreas is this area that is encased, if you want, or surrounded by the second portion of the duodenum, the common bile duct, and the pancreas. When there is inflammation of that piece of pancreas, surgeons like to call it groove pancreatitis. It is uncommon. It has unclear pathogenesis, but it's certainly much less associated with alcoholism and other diet issues that occur in acute pancreatitis. So groove pancreatitis, the key element is the location. And obviously this is the normal groove. And here a nice example of what happens when there is inflammation, chronic inflammation of the groove of the pancreas that pushes the duodenum a little bit laterally, common bile duct medially, and you see the location of groove pancreatitis. So these are nice examples when you see pancreatitis that extends to the groove, pushing the duodenum, as we just mentioned. This is in MR, this is in T1, this is in T2, a little bit edematous, and again, this is the appearance pushing the duodenum and the common bile and the hepatic flexion. You see it here with a little bit more advanced delayed gadolinium. This is the groove pancreatitis compressing the areas, and you see it here when you see that indentation medially and the indentation laterally of the duodenum. You have to think that this is potentially a patient with groove chronic pancreatitis. This is a little bit more groove pancreatitis, but with pseudocyst formation. It can be seen as a pseudotumor. This, you see the displacement of the hepatic flexure, but how it is chewing on the duodenum. and obviously findings of chronic pancreatitis with dilatation of the pancreatic duct and the atrophy of the tail and body of the pancreas. You see it here, the septations nicely depicted in the T2 appearance, and this is classic pseudocyst formation with a pseudotumor sign in chronic groove pancreatitis. You see it here in coronal. This is the same patient, T2. You see the medial displacement of the pancreatic, the common bile duct, and the lateral displacement of the duodenum by a classic appearance of groove pancreatitis, correlating, I would say, beautifully with the diaphragm I showed you. Another distinct type of chronic pancreatitis is the so-called autoimmune pancreatitis. You see it as, again, a distinctive type. Less than 7% of chronic pancreatitis is associated with autoimmune disease, and typically no gallstone or alcohol-induced pancreatitis. Alcohol and gallstones that have the lion's share of the etiologies for acute pancreatitis. And of course, if chronic pancreatitis do not play a role in autoimmune pancreatitis. The symptoms of autoimmune pancreatitis are mild. They improve like many other autoimmune diseases with steroid therapy, but I've mentioned it because the same way that location is classic for groove pancreatitis, for autoimmune pancreatitis are the findings that we see in imaging that allows us to find a diagnosis or to commit to a diagnosis of autoimmune pancreatitis, because some of these findings are pretty typical. We have known for about 10 years of periductal, of chronic pancreatitis. Some of the research came from Dr. Duchesne Sahani, who was at the Mass General, was one of my colleagues, and then moved to University of Washington. So what it is periductal inflammatory infiltrates with lymphocytes and plasma cells that characterize this periductal inflammation, produces with time extensive fibrosis with destruction of both acinar cells or exocrine pancreas and islet cells or endocrine pancreas. Autoimmune pancreatitis can be focal or diffuse and is characterized by a narrowed pancreatic duct and a dilated common bile duct. We'll see some examples, but the imaging criteria is either focal or diffuse enlargement if we are dealing with focal or diffuse immune pancreatitis. But it is classical to have a peripancreatic halo or rim of decreased density around the inflamed areas. We'll see that very clearly, that it is like a little, if you want, capsule that surrounds the pancreas, that is because it's decreased signal or soft tissue density, but does not enhance because it's basically fibrotic. The pancreas with this peripancreatic halo becomes like a little sausage, losing the classic acinar lobulations, and it's a sausage sign of pancreas, of autoimmune pancreatitis. The pancreas not only becomes sausage-like, but also shortens, and can have segmental or diffuse narrowing of either or both the main pancreatic duct and the common bile duct. And then in the biliary tree, autoimmune pancreatitis, that some people also think is autoimmune cholangiopancreatitis, may have cholangitis-like strictures. Again, can involve even a third organ, not only the biliary tree, but also the kidneys. From an embryological standpoint, you have to remember that the biliary tree and the pancreatic ducts are the same. It's a little outpouching of the duodenum, basically small bowel line is a small bowel epithelium that differentiates into biliary and pancreatic epithelium that are indistinguishable. They are the same, but obviously the biliary epithelium, it's in the common bile duct and in the intrahepatic bile ducts, and the pancreatic epithelium is in the pancreatic ducts surrounded by pancreas. So this is the halo or surrounding that nicely seen in both CT and MR, and the shortening of the pancreas becoming like a sausage, maybe a little bit of peripancreatic inflammation, but this is the sausage with the hemangioma here in T1 in the liver. Classic example here in T2, you see better because of the visualization of the fibrotic capsule surrounding the pancreas. And you see it here as well. Nice examples with a shortening and the sausage-like sign of the pancreas. Nice examples of diffuse autoimmune pancreatitis. This is after administration of gadolinium and enhances in this case, but you see again the halo sign and the foreshortening of the pancreas, classic of autoimmune pancreatitis. There may have associated nephritis, and again, it reduces or becomes better after a month of steroid therapy. You see here more autoimmune pancreatitis localized to the head with peripancreatic findings, and then after a month of therapy, the associated nephritis got resolved. The evolution is again the diffuse enlargement of the pancreas, the more formation of the halo, and again, the good response to steroids is a good predictor of the evolution of autoimmune pancreatitis. I want to finish in 5 minutes, if we take as much, about something that in some centers is requested. Gastroenterologists like it, which is the so-called SMRcp or secretin-enhanced MRCP. Secretin is a normal hormone produced by the duodenal epithelial cells under the stimulus of gastric acid. This gastrointestinal, if you want, hormone goes into the bloodstream, and then the secretin, hence the name, it stimulates the secretion of fluid and bicarbonate by the exocrine pancreas. Also, the secretin increases the tone of the sphincter of Oddi. So when we have gastric acid going from the stomach into the duodenum, there is secretin produced by the wall of the duodenum. The secretin goes into the bloodstream, stimulates the secretion of pancreatic enzymes, and at the end facilitates the digestion. So there is a product, secretin, obviously it's not human, can be synthetic or can be porcine. Actually, the typical now is synthetic with less allergic complications. It's given IV to the patient and then has a short lifespan, very much like the natural secretin that we produce when we eat. And within for the next 15 minutes, you have to do dynamic imaging of the pancreas. And obviously, you will see the increased secretion of the pancreas. You see kind of beautiful MRCPs because there's more pancreatic juice. And obviously, you can potentially evaluate the degree of chronic pancreatitis because post-secretin in patients that are normal, let's say a young, healthy patient, you will see the rush of pancreatic juice into the common bile duct and the duodenum. In patients that have severe chronic pancreatitis, nothing happens. And the very thin pancreatic ductus you start eventually doesn't move after the administration of secretin. Dr. Matos is a Portuguese radiologist in Belgium who has written a lot about secretin MRCP. And if you've got wills and it goes well, I can show you maybe here examples of secretin pancreatitis. It worked with me, but maybe it doesn't want to work. But you will see here the secretion, increased secretion in the dynamic MRI. About to finish, 2 minutes to go. We have gone about acute pancreatitis and chronic pancreatitis. We talked about CT and MR findings. We talked about the specific subtypes of chronic pancreatitis, the groove and immunologic pancreatitis, one by location and the other one by imaging appearance. You can diagnose with pretty accuracy and certainty with CT and MR. Let's spend a couple of minutes before question and answer session in appropriate utilization. So appropriate utilization is an effort of the ACR to produce guidelines. The intention is not to tell you how to practice, but to give you guidelines that in the most recent years, since the early decade of the 2000s, includes not only the rating, but also the relative radiology exposure, basically. So the RRL. So at the end of the day, for severe abdominal pain, elevated amylase and lipase, fever, and elevated white blood cell count, the preferred method would be, as I've mentioned, acute CT if you want, with or without contrast, but CT provides the better evaluation of acute pancreatitis. And in this group, there are radiologists and pathologists. But I also want to mention that for less severe pancreatitis, variant 1, with the first episode of pancreatitis and known etiology, it is suggested that ultrasound may be very helpful as the first pass, because primarily the RRL is none versus CT, that it's medium depending on the age and overall conditions. With this, I am about to finish. I tried in this 45 minutes to mention my point of view in pancreatitis, common and critical. And now I'll be happy. I'm going to stop sharing the screen, and I'll be happy to take questions. And I believe our President, Dr. Kevin John, will provide the moderation for this segment.
Thank you, Dr. Ros, for that informative lecture. If anyone has any questions, they can either type in the chat or raise their hand and I can unmute you.
All right. You want to go through the chat or whatever you want, it's fine with me.
Sure.
Maybe you can start with one of the Q&A in the chat.
There are currently no questions in the chat.
There's a Q&A.
Okay, here's one. How does pancreatic divisum predispose to pancreatitis?
Well, very good question. Pancreatic divisum, obviously, it is an abnormal drainage of the pancreatic duct, and it's basically an abnormal configuration of the pancreas. The area drained by the pancreas divisum, which is the ventral portion of the pancreas that in normal anatomy, it fuses with the rest of the pancreas, has basically a different architecture of the common bile duct and predisposes to not as a normal or expedite drainage, and that produces chronic inflammation. And this is one of the rest of the pancreas is fine, but the area that it's drained by the accessory duct, the pancreas divisum area, doesn't drain so normal. And it recurs and sometimes ends up with surgery. Other questions?
Okay. There's one question. Do you use the classification, the Balthazar or Atlanta? Which one do you prefer?
Well, I mean, as I've mentioned, there are several classifications. The idea is to produce a severity index that will alert, based on MR and CT, will alert and complement the clinical index that the gastroenterologists use. I think it's at the taste of the radiologist. The Balthazar CT criteria, staging criteria for pancreatitis is used widely because it was the first one, but it is less comprehensive compared to other classifications. It depends on your particular taste and also what the gastroenterologists are used to. Obviously, in large departments where there are 7 or 8 radiologists reading CTs for acute pancreatitis, should be a single criterion for the whole group, since you're going to be reading different people and you don't want to have consistency. It doesn't, my weight doesn't really matter. We used to use a lot the Severity Index at the Brigham because it was a big pancreatitis center, but we have not been asked or requested by the gastroenterologist to use it either in Case Western or here at Stony Brook. And it depends. It depends on the clinical situation for each department. Bottom line, it depends on what you like. I think that Atlanta or the one that we produce are a little bit more all-encompassing, are better, but it has to work for you, basically. What else?
The next question from Jindera Bhagat. In pseudocyst formation, is the pseudocyst formed by pancreatic ductal dilation or fluid collection due to inflammation?
Well, it's a granulation tissue that forms typically around these peripancreatic fluid collections that we call them phlegmonous. It's not really fluid. If you would look at it, if you go to surgery or see the drainage, it's like crankcase oil. It's a very dirty, foul-smelling, putrid, basically autodigestion of the own retroperitoneum by the pancreatic juice. So it is this phlegmonous fluid that is tried to be encapsulated by the body with granulation tissue, and it's typically the peripancreatic pseudophlegmons. Occasionally, there is marked focal dilatation of the pancreatic duct that can also be considered pseudocyst formation, but it's typically not the pancreatic duct, but the area surrounding the pancreas.
Another question from Enrique Minero. In complications of pancreatitis, do you recommend MRI or CT for evaluation of these?
Again, I used to work with a surgeon that liked MRI because he was very concerned because he had had several major issues with patients with pancreatitis that had hemorrhagic pancreatitis. But at the end of the day, the easiness for these patients that are critical sometimes of CT, that in some hospitals there is a CT inside the ICU, and the CT can be done in 10 minutes. CT is in general preferred. But again, the major advantage is to find acute blood, which MR is more accurate than CT, and also for the SMRcp. But again, depends a little bit on the taste of your clinical team. MR has more complications because the patient is going to be inside the machine for an hour. If the MR is not available, we'll wait for an hour outside, and these are ICU patients that the excursions they have outside the ICU, the better it is. I had a recent chat, somebody was asking me if a pseudocyst can be in the mesentery. Well, almost always the pseudocysts are either in the retroperitoneal fat that connects with the mesentery, and the same way that frequently there are pseudocysts and phlegmonous collections that go into the liver, the pancreas, the spleen. They very frequently extend for the retroperitoneum where the pancreas lives through the subperitoneal space into the small bowel mesentery. I would say very common.
I have a question from Ernesto Espinoza. What is the preferred strategy for necrotizing pancreatitis when percutaneous drainage doesn't result in resolution?
But I think that modern, if you want to advance interventional gastroenterology, will do with endoscopic ultrasound guidance a gastrostomy, a pancreatogastrostomy, and they put a valve that is a metallic valve that we see that opens a gap relatively large, maybe a couple of centimeters, maybe one plus centimeter opening between the pseudocyst and the lesser curvature of the stomach that is touching it. So the interventional endoscopist opens the stomach, deploys very much like the cardiologist will deploy a valve, will deploy this valve, if you want, that opens a connection between the stomach and the pseudocyst maybe, but also peripancreatic phlegmon. That I think is the preferred method. If not, will be open surgery, which is used to be done much more often than now with this endoscopic ultrasound, but also percutaneous drainage is commonly done by interventional radiology. We have 5 minutes left. If there are no more questions, maybe one or two more. If not, we'll call it a day.
There are currently no questions in the queue.
No more
if anyone
questions.
has
Any burning
no.
question by anybody? If not, we'll call it quits. Thank you, everybody, wherever you are, from far or near. Thank you all for participating. Have a great weekend, and we are getting close to the RSNA, getting close to the holidays in North America and the world with New Year's and Christmas and the Thanksgiving for us. So if you are going to celebrate the holidays, safe holiday season, don't eat too much. And if you're going to the RSNA and you see me around, say hello, tell me I was in that Health for the World webcast, and delighted to, or Zoom meeting, delighted to have had you for the rest hour. And John, Kevin, I'll see you in a couple of minutes reading cases today. Kevin is assigned to me today, or I am assigned to him. So thank you, everybody.